Thank you, Donna. It's now my great privilege to introduce our 2008 Convocation guest speaker, Dr. Lisa Iezzoni. Dr. Iezzoni has a medical degree and a degree in policy management from Harvard University. She was the first woman to be appointed professor in the Department of Medicine at the Beth Israel Hospital. She was the recipient of the Investigator Award in Health Policy Research from the Robert Wood Johnson Foundation and is a member of the Institute of Medicine at the National Academy of Sciences. And she's currently Professor of Medicine at Harvard Medical School and the Associate Director of the Institute for Health Policy at Massachusetts General Hospital. Dr. Iezzoni has published widely on the topic of policy issues for persons with disabilities and on methods for predicting costs and clinical outcomes. She's authored 3 books in the past couple of years, one entitled More Than Ramps, A Guide for Improving Healthcare Quality and Access for People with Disabilities, When Walking Fails, Mobility Problems of Adults with Chronic Conditions, and Risk Adjustment for Measuring Healthcare Outcomes. Welcome, Dr. Iezzoni. Thank you.
Somebody just make sure I'm wired, because I always worry that people can't hear me. Am I okay in the back of the room? Yeah? Here? Okay. Thank you for inviting me to speak with you today on this, which is your special day. This is the moment that we honor the tremendous achievement of the graduates, and we also honor their family members and friends who have provided, thank you, support and sustenance along the way. Through your hard work, some for more years than you might care to remember, you graduates have mastered core knowledge in diverse fields. You are about to spread out across the country into a variety of careers and continued schooling in varying settings, from homes of individual patients to schools and workplaces to healthcare facilities to colleges and universities. But despite this diversity, you share some critical attributes that I'd like to touch on in my brief comments today. First, you chose your careers well. The massive demographic wave that is about to hit the United States, the aging of the baby boomers, the generation that most of the parents in the audience represent, is basically a guarantee of full employment for the rest of your working lives. And though the parents may not like to hear it, few of us baby boomers do. Aging generally brings with it changes to our bodies, our abilities to see, hear, get around, and perform other routine activities of daily life. Furthermore, with a growing obesity epidemic among children and young adults, some observers worry that disability might arrive at younger ages in coming decades, expanding your potential patient pool even further. Many of you as clinicians will deal directly with the consequences of aging and disability. So for the parents in the audience who worried if your child could ever get a job, the answer is absolutely yes. And it is largely because your children will be caring for us. Second, as clinicians, you share a focus on your patients as whole people, rather than, as so often in my field of medicine, as individual body parts. You frequently go even further. You think about your patients as whole people as they live their daily lives in their homes, schools, workplaces, and communities. You think about your patients' interface with their social and physical environments within which they live. Yes, I know that some of you have focused on specific human functions, but how can those of you who have specialized in nutrition or dietetics, for example, not think about many factors beyond the foods your patients eat, to whether they can afford to buy healthy foods, whether they live in neighborhoods with stores that carry fresh vegetables and fruits, whether their cultures and traditions affect the foods they choose. For each of your specialties, I could paint a picture like dropping a pebble into a pond and watching the water ripple outward, where, as clinicians, you might start with a specific focus, but to truly care for your patients, you must think much more broadly. The third shared attribute flows from the second. That is the need for you to partner with your patients so that you understand their goals and come up with plans together to achieve those goals as best as possible. Many of you have heard about the crisis in healthcare in the United States today, a topic much discussed on the presidential campaign trail. Much of that crisis relates to escalating and unsustainable costs, but another critical concern revolves around quality of care. Study after study shows that healthcare quality isn't what it should be, especially for certain subgroups of patients, such as racial and ethnic minorities and individuals with chronic diseases and disabilities. In a seminal report published in 2001, the prestigious Institute of Medicine wrote that one essential step to cross what they called, quote, the quality chasm, was for healthcare to become patient-centered, to focus on meeting the goals, expectations, preferences, and values of individual patients. The professions many of you are joining today have long traditions of being patient-centered. Patient-centeredness is integral to the way you approach your practice. Now, I know this won't always be easy. Sometimes patients just won't do what you think they should do to achieve the goals they themselves have set. For example, they won't use that cane or walker or perform their exercise routines as often or consistently as they should. But I urge you during such moments of frustration to remember what you intellectually know is true, that many of you will be addressing the most basic activities of daily life, such as how people get up in the morning, how they hear and speak, the meals they prepare and eat, how they move around throughout the day, how they organize their homes. Unless you partner with your patients and understand their points of view, you won't be able to put together care plans that will work by fitting within the daily lives and sense of who they are as people. So on to my final point about what many of you share. That is an opportunity to truly make a difference, to improve people's lives in the most basic and fundamental ways. Part of that opportunity to improve lives comes from your clinical focus on what many Americans value most, and that is their independence and freedom. I urge you to be creative and open-minded when, in partnership with your patients, you think about care plans that can best ensure patients' abilities to live and function independently in their homes and communities. And most importantly, I urge you to remember that independence doesn't always mean patients must do things alone. The measure of success isn't how patients get around, for example, but that they find alternative means to achieve independent functioning when their bodies cannot. I'll use myself as Exhibit A to make that point. Many of you in the audience have seen me rolling around on the stage, and thoughts flash through your mind about me based on the fact that I use this scooter wheelchair. You probably had many thoughts, but one of them likely was I was a treatment failure. I was someone whose legs the professions that we celebrate today couldn't fix. Okay, I'll concede that point. None of you, from the newest graduate to the most seasoned clinician on this stage, could have made my legs better once multiple sclerosis started working on them more than 30 years ago. That is my reality. Many of the patients you will see, those with spinal cord injuries, stroke, amputations, and other devastating, debilitating diseases, will have fairly stark realities. But for many of us, there are alternative ways to do things, ways that you can help us find. I'm not a treatment failure. Given my reality, I'm a treatment success. This scooter is my treatment. It makes me mobile. In fact, anticipating traffic gridlock, I rode my scooter over to Newton, the T-stop, got onto the red line, or the green line, and got off at Fenway Park. I didn't realize there was a Red Sox game today. It wasn't a good thing. The game started at 1:30, but here I am, coming on the subway quite a distance. Now, I haven't told you the whole story. I got this scooter in 1988, yes, that's 20 years ago, but I should have gotten it years earlier. By that point, I probably had MS for almost a dozen years, and I was falling frequently and finding it impossible to walk the distances that my daily life demanded. Plus, my work required me to travel frequently. How could I carry a suitcase when I needed 2 canes to stay upright? But I was stubborn and ashamed, embarrassed at the thought of being seen in a wheelchair, worried that people would think I was lazy or didn't have the strength of character to try to keep walking. And I did not have a physical or occupational therapist. A good therapist would have talked to me and found out my point of view. A good therapist would have understood my safety risks and thought constructively about how to get me to understand the practical advantages of wheeled mobility aids outweighed my psychological trepidation. A good therapist would have suggested that maybe I experiment with a scooter or wheelchair, rent one perhaps for a few months, or not use it all the time, but maybe just take it on trips to see how it worked. A good therapist would have realized that working with patients requires patience and sometimes finding the right hook to encourage and motivate change. When I first started using my scooter, I couldn't stop smiling. I often still find myself grinning as I spin along, no longer afraid of tumbling and free fall. I'm going places, making tracks. It feels like a spring after a housebound winter. Over your long careers, you will give countless patients the same gift of freedom and independence and make numerous lives better. So let me stop talking now so you can go out and celebrate and then get started on your professional lives. Our collective congratulations and best wishes go with you. Thank you.